I would challenge the notion that that just because you have a profit motive or because that you want to be efficient or productive with the resources, because they are scarce resources, whether it's hours, medical supplies, drugs, whatever, they are scarce resources. That it doesn't have to be either or; it can be and. And I think some of the best run organizations with that visionary leader at the top, motivated, folks around a mission of providing top-notch care. When everyone kind of buys into that and works together to provide that, you can have unbelievable care that's provided at a very efficient, an efficient manner.
So today I'm joined by Nathan O'Leary, and we are here to talk about everyone's favorite subject, money. um, Nathan, you've been in the finance sector. That's what you do for your job. You have your MBA degree, and you are a certified public accountant. And you've been in the financial industry for 23 years, and 15 of those have been in like the healthcare sector part of
That's correct.
part of finance. So I think you have some good experience in the healthcare sector, and also outside of you've had some experience in other areas of finance. So I think you can bring a good, well-rounded ideas and thoughts and knowledge about how finances work, specifically in healthcare.
Well, I appreciate that. I know your discussions are around healthcare, and as you said, everyone's favorite topic, the financial side of it. And it's good to talk about these things, about being responsible, resourceful with what we have. And oftentimes it's when people talk about the finances of something, they think, oh, the Neanderthals are going to come after our money and just cut everything, right? And I consider myself a caregiver of sorts, even though like you said, I'm a CPA. I sit behind a laptop, but I help support our caregivers, and I very much view my role in that regard. And I think it's important to look at the numbers, behind what we spend, where it goes, different things like that. So I appreciate the opportunity to bring up the subject.
I think most people have a hard time understanding the money and the numbers in healthcare. I've worked in the hospital for almost 20 years, and I know just talking to coworkers, they just like, no one knows where the money goes. No one knows like, how does, we take care of patients, but it's like, how does the financial side work? And
Feels
I
like a
think
black hole, right?
even like in working in the hospital, most people don't know just basic. I don't know basic stuff about how finances work in a hospital healthcare system. So I'm interested in learning more. I think it's an interesting subject, and you know, healthcare facilities have to balance. They have to be profitable. They have to make money, um, and but they're also providing a necessary service.
Yep.
So they have to they have to balance both, providing a service, but also they have to be profitable, or they shut down, or they don't exist anymore. So I guess just start with just some general numbers about the the finances of like how much money is spent on healthcare in America, and just a general overview of the healthcare financials in the United States.
So the good thing about the United States is, we're obviously a prosperous nation, and there's a great desire to invest in health and healthcare, in extending life and creating value in life. And so I think that's coming from a really positive place where there's a great desire to invest in that. And like I was mentioning earlier, it's kind of like a negative thing if someone recommends a cut, to spending. And I'll talk through some of the numbers here, but it's amazing to think we spend as a country $5 trillion with a T on healthcare every year. Now, healthcare is a broad subject, right? I mean, that doesn't include like vitamin supplements and things like that. We're talking about actual care that's provided through hospitals, through long-term care facilities, through dental care, vision care, different things like that. But as when you really think about healthcare and the costs around that, as a nation, we spend about $5 trillion a year In 2024, it was $4.9 trillion. And you think about that, like that's like monopoly money. Like how do you how do
It
you wrap
doesn't
your
make
head around what
it's
that
too.
is?
It's like $1 trillion. What it doesn't even. You can't even understand that number.
Well, think about it like this: if there's 340 million people in the country, that's about $14,700 per person. 14,700 for every alive human in our country. If you think about it in terms of who pays for that, then for every working adult, that's $37,000 per working adult that is spent on healthcare every single year. That's how you get to 5 trillion.
That's that's 16, $17 an hour job. That's a full salary for like a $17 an hour job every year.
Exactly. That's what it would that's what it would add up to for a full year.
So, $5 trillion. Where does that money go? Because you hear, like, I don't like me. I know that's an average, but like I don't spend $37,000 on my healthcare. We have insurance, which is a monthly expense, and if you have to go to the doctor or ER or whatever. So where's the actual dollars going to? Like, in the healthcare facility or insurance companies, or can you kind of break down
Yeah.
where's the money going to?
Yeah, and in some cases you have to like put the pieces together, right? Because in a lot of cases, especially with government and publicly reported information, it's not that difficult to track. You just have to be patient and know where to look. But then there's a lot of not-for-profits, privately owned organizations that also are recipients of those funds, and so there is estimates that's made. Even the 5 trillion in and of itself is a bit of an estimate. But when you break down like where that money goes, roughly a third of it goes to hospitals. About 31% every year is spent just on hospital care. Another 20% on doctors and clinics. So roughly, you look about just over half of our money is hospitals, doctors, and clinics. You're like, where does the rest of it go?
And that's like, I would consider. I mean, there's some people who even break it down to like, that's considered sick care. Like going to the hospital, doctors is kind of like, that's not even taking care of yourself in a way that you're like making yourself healthier. It's almost like that's when you're sick.
Yeah.
So that's how
That's
much
what we're
money
looking
is
at it.
being spent on when you actually need emergency services or something like that.
And a big part of that as well. And whether it's before you're sick or after you're sick, there's sometimes a fine line with that because then there's like chronic illnesses, right? There's kind of a buzz in the industry about, why are we spending so much just on chronic conditions? And we spend over 10% of that 5 trillion just on prescription drugs. So it's just a huge amount that goes into there. Roughly the same amount, about 8 or 9%, goes to administrative costs, just to run these programs, to run hospitals, to run clinics, all the providers. About 5% goes to long-term care, so there's a portion there. Another 8% goes to like mental health. There's another portion that goes to like research and development, which is actually a smaller percentage than you might think. Another 5% goes into like dental care, vision care, different things like that. Another 5 or 6% is invested back in like medical equipment, supplies, different things like that. So you can start to slice and dice it pretty small. But overall, you can kind of get a sense for, where our money goes. What's interesting is about 3% of that is insurance company profits. And, another 5 or 6% of that goes to like government programs and government health, run public health type things. So, there's a lot of different places that go. And that's what I said at the top. It's like it's a great desire in our society to spend money on these programs. The quality of life and the health that we enjoy as Americans is worth investing in.
And I know a lot of that money that's even spent in hospitals and like post-discharge there's a huge chunk of it that's spent like in the last, year of someone's life.
Yeah, I don't have the stats around that. I've seen something similar as well, and to some extent, hopefully, we're not spending a lot of money on healthy 20-year-olds, right?
Yeah.
And money is spent where the need is greatest, and so around end of life care, it ends up being something that is not inexpensive.
So what are some things that make it so expensive? Like I know you broke down the numbers like, administrative and what the hospitals make, but just in general, why is it, like, is there waste? Is it just high salaries or, just, the people need to make a profit when they're running their businesses, insurance companies and stuff like that. But what is the reason for so much money being spent, or is it just that we're just sick and it's just a necessary thing?
Yeah, that's a loaded question. So what I want to do is take a little bit of a kind of a two-step approach to do my best to answer it. First is when you look at every $1 spent on healthcare, like we talked about it going to hospitals versus doctors versus vision, things like that. But when you look at every $1, and again, some of this is theoretical, somewhere around 55 to 60% of every $1 goes towards labor, salaries and wages. So doctors, nurses, social workers, dietitians.
Is that do you know if that's pretty typical for like other industries? I mean, like, is labor one of the about 50% in most industries, or?
Yeah, so it's going to depend on if the industry you're in is a service-based industry versus, more of a like a product-based type of an industry. So typically, when you're providing a service, the greatest input of value is going to be the labor that's associated with it. And so, 60% is probably a little bit more on the high end of what you're going to find in most service industries. But then you also have to consider the skill associated with it, right? Like a doctor goes to school for a while. Nurses are highly skilled. Social workers, dietitians, others that are part of that care team have a lot of education wrapped up in that, right? And so there's some more value associated with that. That's just my perspective. I don't have any statistics around that. But 55 to 60% is probably a little bit on the higher end when you look at like other service industries. But it's pretty consistent when you look at across healthcare as a whole. Now we think about, okay, so that's just over half. Where does the rest of it go, right? And healthcare, there's a lot to providing healthcare. So you've got the medical supplies and the pharmaceuticals, the drugs that go into it, and that's right around 15% of every $1 spent goes to the bandages and the pills. When you look at things like the facilities, hospitals are oftentimes huge and beautiful, right? They got to keep the AC on. They got to keep the lights on. And so, think about overhead and facilities and different things like that. That's typically another, say, 10 to 15%. And these are generalities, right? You look at a hospital and what they're going to spend on their facilities, it's going to be a little higher than some, say, small doctor's office that maybe doesn't have the same infrastructure and things like that. So we're talking about it in more generalities. So you're looking at about, 60% labor, another 15% drugs, supplies, another 15% facilities and overhead. That's where the bulk of it goes. And then you look at things like billing and insurance processing, legal, HR, accounting. Folks like myself who, I consider myself in healthcare. Obviously, I've never stuck a patient in the arm. You wouldn't want me doing that either. But administrative costs can be anywhere from 5 to 10% of each of those dollars. You look at another 5-ish%, sometimes as high as 10, but usually around 5% is for capital equipment, larger type purchases, things like that. The sad part of it is you look at it, somewhere between 2 and 5% is for like malpractice and things like that, right? Insurance coverage and payouts and different things like that, which has an impact on the cost of the system. And what's interesting is profit is somewhere around 0 to 5%.
Just an average between hospitals, doctor's office, clinics, all those things.
Yep, Absolutely. There's not as much profit in the system as you might think. Now, there are some organizations, and within healthcare, you see a lot of not-for-profits, charitable type organizations, ones that might take on a challenging patient base and struggle. I think about the county hospital just in Minneapolis that we have there, Hennepin County Medical Center. It's a county-run hospital. It's an inner city, very challenging, census base there. They lose tens of millions of dollars a year. And then others, based on where you live in Tampa, a lot of folks with private insurance and things like that, which can actually lead to greater profits. And I don't know specifically what the county hospital does in Florida, but depending on where you operate, what your profit motives are, they can have a huge impact on that. The organization I work for is a large publicly traded company, and we are profitable. We are quite profitable, actually. And so, a lot of it will depend on profit motive.
So the hospital you mentioned in Minnesota, do you know if it's a public or private hospital?
Yeah, it's a public hospital. It's basically subsidized by the county.
I was going to say, what do they, I mean, it's one of those things that we were talking about, like, they have to provide us, like, you need health care. But you do, even as a county hospital, you do want to make money. I mean, you do want to, there's got to be you would like to, I guess there doesn't need to be, but you would like to have an emergency fund. You'd like to have, room for growth. You always can be upgrading how the hospital looks and equipment and stuff like that. Absolutely. So what do they do when there's the government basically has to step in when there's a shortcoming in the budget?
Yeah, it speaks to the ownership structure. It speaks to the profit motives. In a place like an inner city, county type hospital, there isn't a profit motive there. It's really to service the needs of the people that live there, right? And so, it is to the extent that the people that live in Hennepin County are there in Minneapolis, to the extent that they're willing and able to subsidize a hospital like that, then they do. And the people of Minnesota have effectively chosen to do that. That hospital, I mean, it's, again, haven't seen their financial statements, but it's in the news where they'll lose tens of millions of dollars every year. And so that kind of leads to, I know you and I were talking earlier as well about, like, what are some of the factors that could increase or decrease profitability, right? And there's a lot of things that play into that. It's kind of a long list, but I'll call out some of the things because they might be interesting to folks that are listening to this. But one of the biggest things that's going to come into play, I talked about profit motives, because if you are for profit, you are going to have a kind of a ruthless, say, pursuit of productivity, right? Like, productivity matters because you can't be wasteful if you're looking to have a profit motive. And I can tell you, even from the organization that I work for, just because you're productive doesn't have to have an effect on profitability or care. The organization that I work for has some of the highest care scores in the industry, and yet we're extremely productive, both in terms of the hours that are used and the supplies that are used and things like that. But what are some of the levers that you can pull then? A payer mix. When you talk about payer mixes, in our country, literally almost everybody has somebody who insures them, right? Whether it's some sort of a government plan or whether it's a private insured plan. And typically, the private insured patients are their treatments or their care are reimbursed at a higher rate than what a government plan is going to pay at. So
private, just to clarify, private insurance would be like through your job.
Correct.
Or if you go out and get through whatever, Aetna
like
or
Blue Cross
or
Blue Shield, or yes.
And government would be Medicaid, Medicare.
Yep. Or some sort of you've got Medicare Advantage, there's different things like that are essentially either paid for or subsidized by the government.
So the private insurance reimburse at a higher rate?
Remarkably higher. In some cases 10 times higher, some cases 20 times higher.
So that's like when you go, so that's how much like the doctor can collect or how much the healthcare facility can collect
Correct.
through private insurance.
That is correct.
So that
So the mix that you're treating, and so let's say that you're a doctor's office, and you have 50% of your patients with private insurance, and 50% of your patients with some sort of a government plan. You're going to have, let's say, X for profits. But then if you're able to change that percentage, instead of 50% of your patients with private insurance, 60% are, and only 40% are government, you are naturally going to have more profits if everything else were equal.
right, right. That makes
So
sense.
payer mix is a really large lever, and that can, you know, the socioeconomics of a market, of a state, of a city can play a big factor in that.
I've seen just in Florida, I don't know about nationwide, but there have been a lot of physicians who have gone what's called concierge. That's what it's called where around where we live is concierge,
Okay.
where it's cash, and so they don't. I mean, like if a doctor's concierge, you pay them like a monthly or yearly fee
Yep.
to see them, but then if you go to the hospital, you still pay with your insurance. You're paying the hospital with your insurance, but I think that's one way that kind of practice probably brings in a different kind of money making,
Sure.
just a different way to make money.
Sure, absolutely, absolutely. So payer mix is a big one. Just your volumes can make a big difference because you can be more efficient in theory. You can be more efficient with more patients, more treatments, more more folks in beds in a hospital. So, for example, a hospital in Chicago, which even if their payer mix is lower, potentially, if they can make up for that with volume versus a hospital in the middle of Wyoming, which might be a 15 or 20 bed hospital and maybe don't have as many patients in there. So the volume of patients or treatments provided or services provided can have a really big impact on what your profitability is, right? We talked about a little bit about it earlier, but just efficient operations. And some of that's going to come back to your profit motive, right? Lean staffing models, effective scheduling. The company I work for has invested heavily in just efficiency in staffing models. So, we don't want to sacrifice the patient care, but we know that one nurse can take care of so many patients or care techs can take care of so many patients. But we don't want to run into a situation where if there's not as many patients there where we have additional nursing. And so, there can be very effective ways of managing through that to kind of, again, not sacrifice the care, but make sure that you are being very efficient. You can really streamline billing and claims processing. Revenue cycle management was this buzzword a few years ago, and just learning how you file claims and the timeliness of that and what you're claiming on those claims and whether you claim code 1, 2, 3, or 4, which are all very, very similar. And so just, your efficiency in billing and your accuracy in billing and your timeliness in billing can have a huge impact just on your operations. You can provide the best care in the world, but if you're not billing for it, you can't collect on it, right? And then, use of electronic records has been a huge win. Less paper, just more efficiencies in the system has been huge.
Less paper, not no paper.
Less paper. Very
Less
good.
paper.
Very
I remember
good.
when they said electronic records and all that, they were going paperless, and I'm like, I still deal with hundreds of papers a day.
No doubt, right?
Yeah.
Another thing that's really been emerging, say in the last decade, is like technology and telehealth and different things like that. Those help take a lot of costs out of the system. We talked earlier about the costs of the brick and mortar, right? When you can provide top care in a telehealth environment, there's reduced costs associated with that over time. And so there's a lot of things like that can really help lead to that. Other things that can help push or be a pull on profitability is just what is it that you do? The industry that I work in is dialysis, kidney dialysis. And, we're pretty restricted in terms of what is provided and rates are kind of locked in. But, if you're a hospital and all of a sudden you're providing, say, more orthopedic care or more cardiology or more radiology, oncology, some of those are very, very high revenue generating services. And so if you do more of those types of services, you're going to make more money versus some of the other specialties. You mentioned earlier the doctor who is kind of like on a cash basis, right? And essentially what he's doing is he's pooling the risk of his patient base and saying, hey, if everybody pays me a little bit every month, I'll take care of you up to a certain required level of care, right? And the government in the last decade plus has also dabbled in some of these value-based care models, these risk-sharing models, and they're getting more and more complex. Our company also engages in a lot of those, and if you can prove that you are pulling costs out of the system while not sacrificing the level of care, there's opportunities to share some of those savings. And it's less focused on a fee for service, paying for a transaction. You know, you do this and I'll pay you this. It's more, I'm gonna take care of Marcos, and whatever you need, we're gonna cover for it. But if you need a lot of care, we don't charge more, and if you need no care, we don't charge less. It's just this pooling of risk, and then ultimately sharing of those services. Those get extremely complex, and we're kind of like on I would say the cutting edge of a lot of those plans really taking hold. But there's a lot of opportunities there in terms of just value-based care and different things like that.
Have you seen much? I know like AI is starting to make its way into healthcare. Do you see in what you do AI being used to? Because I know they use it in some like staffing to like predict how many nurses they're going to need so that they can try to because you don't need, like, if you only got 20 patients on the floor, you don't need 10 nurses, and so they kind of try to predict, hey, can we like send one of the nurses home if they want to go home. So, you don't want extra nurses just sitting around. And I know it's used in like staffing and patient flow, and then I assume it's used in finance to, I don't know, predict certain things. Do you see any of that?
So we're on the cutting edge of that as well. I haven't seen a lot of it firsthand, and AI is kind of a buzzy catchphrase, I would say, a little bit. What I have seen is we call it like machine learning, and I wouldn't call that full-fledged artificial intelligence, but even in like billing and things like that, when a bill comes in, there's machines that can actually read the bills and create the claims, process payments and different things like that. And so I have seen what I would consider machine learning, which has very much come into play. And I think we're probably, here we are, July of 2025. Maybe a year from now, it's going to be much more prevalent. We're definitely right on the cutting edge of that, the cusp of that, I would say. But I personally haven't seen a lot of that put in place yet.
And that's just all about efficiency. I mean, like, those kinds of things are just
It's hard
trying to be more efficient.
I've read some articles and different things about how artificial intelligence can have some like predictive capabilities, even around like based on say certain clinical results of a patient.
Yeah.
What is that going to lead to? Again, that's more clinical than financial in this case right now. But I don't think that this can be a double negative. I do believe that artificial intelligence is going to have a heavy impact on healthcare, from care all the way through back office, whether it be legal briefs or financial statements or billing and different things like that. I think I would be I'd be foolish if I said that's not going to have a huge impact on healthcare and providing efficiencies very, very soon.
Yeah, I think everyone's kind of wondering what's going to happen. It's like whenever there's any big technological, there was a time where they didn't have computers in the hospital, and I'm sure people were concerned, are we going to be replaced by computers? But I mean, I'm sure there was some things that became more efficient and maybe they didn't need as many people, but, I think it's just people tend to be concerned about the unknown.
Yep.
And when they hear AI, and I think initially the first thing you think of is like, am I going to lose my job?
Yeah.
That's what people are worried.
The reality is a lot of people will, right?
Yeah.
Just like the Industrial Revolution came in, like you said, computers came in. It just changed a lot of the things that we as humans did in terms of the work. And so, it remains to be seen the impact that it's going to have. But yeah, I would say that likely to have a large impact both on the care of the patients, or any of the back office as well that I'm more familiar with.
Another thing that I've noticed in the last 10 years or so is the hospitals and healthcare facilities getting away from, and actually I was talking to a physician who's in their 70s now the other day. They used to have the primary care doctor, and that was, they saw you in the office, they saw you in the hospital, or the surgeon who was actually doing the procedure saw you before the procedure, did the procedure, saw you after the procedure, saw you in their office afterwards. And now I think it's an efficiency thing, because that's what this surgeon was telling me, is that now it's there's a lot of hospitalists who are, they work at the hospital and that's all they do.
Yep.
And even with the surgeons, they have PAs and nurse practitioners that will do a lot of the front end work of seeing the patient initially, and the surgeon will go see him, but it's for 2-3 minutes instead of having the surgeon spend 30 minutes with them, which I don't know that that's a bad idea. It's probably more efficient, and honestly, the way that the surgeon was describing to me was, he said, you actually get more procedures done that way, which can make you more competent in surgery the more procedures you do. And I said, I never thought about that. It could be true.
There's a concept in finance called an opportunity cost, right? And so, the balance, like you talk about with the efficiency, we use the phrase where I working to the top of your license. We don't want nurses doing administrative things when you're paying obviously two very different levels. A doctor that makes $400,000 or $500,000 a year, you don't want them doing something that someone who makes an NP might make $200,000 a year, right? And so if you can, the value derived from the task being done, if you can lower the cost of that, it lowers the cost on the whole system, or it could lead to more profitability, or there's definitely that. But then the opportunity cost, that doctor has less touch with the patients, maybe less opportunity for bedside manner, different things like that. They probably feel more like a machine, maybe than a true caregiver, which again, there's that opportunity cost. Are you going for ultimate of productivity, or do you want like that hands-on touch? And I don't know that we'll ever get it right. Hopefully there's a balance in there somewhere where doctors don't lose that, that hands-on touch care of their patients.
Yeah. And the patients still want to see the doctor too. Although I don't know that really affects outcomes that much. I mean, if a nurse practitioner or PA sees you prior to whatever, or rounds in the hospital, not just for surgery, but makes rounds in the hospital, there's still a practitioner that's seeing you. So I don't know the direct outcome, how that affects outcomes. So
yeah, we were talking a little bit about what can drive profits, and then you look at the other side of that is, what are some of the things that can make a hospital like Hennepin County Medical Center, not profitable? And we talked about the payer mix can be a very big driver of that, but there's other things as well. You think about regulatory burdens, the costs of compliance. There's so much regulation in healthcare, and there's a cost that's associated with that. We see a new bill gets put forth, and everyone thinks it's a great idea to protect this or to, require this. And whenever I hear the word require, I just see dollar signs because costs go up every single time there's a new requirement on healthcare. HIPAA is a wonderful, piece of legislation to protect the privacy of patients. But if you look at the fine print of that, it adds, this is my own personal opinion, I haven't counted the costs, but it adds millions of dollars of costs to healthcare every single year. And so there's drags on that, right? And again, that's the opportunity cost. Do we want, the ultimate protection that some of those things might provide, or are we willing to pay the price for that? Regulatory burden is real. HIPAA, OSHA, FDA, state regs, different things like that just pile the costs on and on. And that's when you talk about the dollar spent that goes towards administrative. A lot of those positions are there and required because of government action, because of government requirements. Another thing I've seen is just labor costs. It's interesting. Doctors and nurses are paid on average double what they're paid in other developed nations. And you might think, wait, what?
Mm.
My wife's a nurse, I'm glad for her opportunities, and we're happy for the salary. But it's hard to think about, like, those costs, can be quite substantial.
Mhm.
Nursing shortages are actually very expensive. Overtime, you think about paying someone 1.5 times their hourly rate for every hour worked. That gets to be very expensive.
Just regular overtime would be considered a bargain during COVID. I mean,
Very possible.
like the amount of it was crazy, the amount of money that sometimes they had to offer to get people to come in, because I think at the beginning people would jump on, well, we'll pay you overtime plus like $10 an hour, and they would jump on it, and then like a year in, they were like, oh, it's not worth it anymore. I know there was
To take those shifts
yeah, to take extra shifts, yeah.
because they're working so much.
Yeah, I mean, at the beginning, there was a little bit extra money, and so they would work 6 days a week, 7 days a week. And then after like 6 months or a year, they're like, it's not worth it to come in.
So there's a toll on the person, right? There's a toll on the nurse because you
Mm-hmm.
can only keep that level of care up, especially in a heightened, say environment where you're putting all the protective gear on and all that stuff. And I'm sure the money was nice, but at what cost, right? There's an opportunity cost there, the cost on the family, cost on, your personal life or whatever. Think about the costs on the system though. If you would have seen what we spent in 2020, 2021, it was very, very high.
So what were you doing during COVID? Was it? I mean, I know it was like crazy. Like, what was the financial world like during that time?
Yeah, I mean, there was, well, this kind of speaks back to the government stepped in and provided a lot of additional resources for companies that stayed open, healthcare organizations that stayed open. Dialysis is not it's a needed service, right? If you have kidney failure and you don't receive dialysis, you'll die. So it was important that our clinic stayed open. And like you were mentioning, we had to pay incentives and different things like that because there was a shortage of available workforce to provide those treatments at that time. And so the costs on the system did go up. In some cases, the government provided some extra layer of reimbursement to help cover for some of that, but profits did drop for several years there just because of the just to get some med supplies became more challenging. Like everybody had their protective gear, right, and all that different stuff. So the costs were quite high, but thankfully that's for the most part in our rearview mirror now.
Yeah, yeah, and a lot of the nurses, I think a big part of the shortage was the nurses left to go travel. At least where I worked, a lot of them went. I don't blame them. They had the opportunity to go travel and just make a lot of money. So they did that, which caused a shortage, like at our healthcare facility where I work. So I know that was something that financially hurt as well. The government subsidies, how do they work? Is that like I mean, the dialysis place will say, hey, we have an underserved community, or they can't afford it. Like, how does that work with government subsidies? Is there like is the county hospital responsible to you know what I mean? Like, how do they contact the government and get more money, or how does that work?
Yeah, this is a very broad topic. So you talk about like access to care and like critical care facilities and things like that. You have a hospital in the middle of South Dakota where the next closest hospital is 100 miles away or whatever. The government has a certain set of rules. You can look them up. I don't have them right here in front of me. That says if the hospital is of a certain size and they're open 24 hours a day, 7 days a week, they will provide a premium to that hospital for those same fee-for-service services that they provide. It's like an additional 30% or something like that. Because with the volume being as low as it is, I mentioned earlier, volume can take a big part in how profitable or unprofitable a location is. And so if there is a clinic, a hospital that's deemed to be critical access, the hospital is subsidized, or that practice or whatever is subsidized by the government with an additional layer, initial bump, based on, the hardship and the, the detriment to that community if they were not to have that facility. We have a dialysis clinic in the middle of nowhere, South Dakota, and even in dialysis, there's an incentive that's given for us to provide those treatments because there's no other clinic within, and I don't remember the exact distance, but a very, very long ways. And so if somebody lives in that area that needs those services, the government helps to kind of prop that up and keep those open.
So that would be like someone who needs dialysis or anything, someone who needs an EKG done in one part of the country, they may charge, I'm just making these numbers up, they may charge $10.
Yep.
But if you're in a rural area, not a hospital around for 100 miles, that hospital may get $100 for that EKG.
Concepts, yes.
Yeah.
If it's $10 in the middle of LA County, it might be $15 in the middle of South Dakota. So it's a bump. It's not not going to make them rich or anything.
But it's to where they can keep the facility open and
Correct.
provide those services to the community.
Absolutely. Dialysis as a whole is actually a government subsidized program or a line of care.
They're on Medicaid, right? Or
Medicare.
Medicare.
Yeah. So when you look at automatic qualifiers for Medicare, or how do you qualify to get on Medicare or Medicaid? Medicare, the most common is an age-based eligibility, right? Once you get to, I think it's 65, 66 years or older, if you're a U.S. citizen, there's these requirements. When you get to retirement age, you qualify to be on Medicare for your coverage for the rest of your life. But then there's other ways.
And that's a little line that comes on your paycheck where you see minus such and such dollars.
You and I pay for our parents' care. That's right. But then you've also got significant numbers of folks that are on Medicare for other like disability-based eligibility. There's kind of a whole, litany of things that qualify you for it. Some of them are mental conditions. Some of them are different things. But end-stage renal disease or kidney failure is one of those things that does qualify you for Medicare. There's some history around that, going back to the 70s when dialysis was first being provided as a service. The science was, able to essentially prolong people's lives, right? Because before that you had kidney failure. If you couldn't get a transplant, you would die within a couple weeks. And so when the science of dialysis came out, when that therapy was being provided, there was quite a bit of demand for it, but not necessarily the infrastructure to provide those treatments. And so it was also very, very expensive to provide a treatment. And so they had these panels, government panels, and you would essentially request the ability to have a treatment. And these panels they were like death panels. They were like yes, no, yes, no.
To individuals?
To individuals. And if you were
at what level was that? Was that like county level, state level, or?
I don't have all the details on that.
Yeah,
to be
it was some kind of like.
Yep, they had these
application kind of.
And so it didn't take very long for people to realize like this is horrible, right? And so Medicare actually, CMS decided that ESRD was going to be one of the automatic qualifiers to be on Medicare, so that the money would be there and the incentive created for dialysis to be provided. And so it like very rapidly grew. And then throughout the 80s, it kind of became its own industry, right? There's an industry around dialysis. And at first it started around doctors' offices and hospitals and things like that. And it has kind of consolidated, over time. There's a couple large players in the country now that provide dialysis services very effectively and efficiently. But now roughly 80% of all patients that are on dialysis are paid by Medicare. About 10% by Medicaid and about 10% by private, like employee group health plans, like we were talking about earlier. But yeah, because of that, that's end-stage renal disease is actually an automatic qualifier for Medicare, regardless of your age.
Crazy, because now you can do dialysis at home.
Yeah.
I mean, like, certain form you can do like peritoneal dialysis at home, which is weird. Like back in the 70s, it was
Oh, that wasn't even a
almost
technology.
could have been I mean, much earlier than that, it was almost like a death sentence. I mean, if you didn't get a transplant,
Correct.
and now they're doing it at home.
Yep. And the costs are much different as well, right? And that's a lot to the technology that's provided, the skill, the productivity that's really put in by, most organizations that provide dialysis have a profit motive, right? They're for profit, and so they're able to provide a high level of care at a low cost. And so, yeah, I'm proud to be part of that. It's pretty cool.
So what happens to like if the government doesn't step in those instances, it's just bad outcomes. I mean, like if subsidies went away, it would directly impact people getting care.
Yeah, it's an interesting thought. I haven't really thought that through. I mean, I'm a free market capitalist, I would consider myself. And so, whether or not government provide, like the fact that government comes in and subsidizes, I don't necessarily see that as a bad thing. But let's say the government didn't do that in your case, and you're a patient that lives in the middle of South Dakota, right? What it might mean is that it might alter your lifestyle. Instead of living in the middle of nowhere, maybe you have to move to Sioux Falls, or to Lincoln, Nebraska, or something like that to be closer to care. That would be kind of a natural change of the way that healthcare would be consumed. Or, depending on if the government wasn't a part of it, would people be willing to pay more for those services if the government were not and they're subsidizing it? Hard to tell, right? In this case, the government does subsidize those programs and help keep them open, which again I don't think is a bad thing. But the market would definitely adapt and change to the type of care that's demanded and could be afforded.
Yeah. And I think we were talking about like the cost breakdown earlier, and I just had a thought about, I mean, I've never like stayed the night in the hospital before, but I hear people getting bills or itemized bills and they see, I don't know, $50 for an aspirin. But then you really think about the process of that aspirin going from the factory to the patient, and it's got to go through the factory, and the factory has to make money, and the workers there have to make money, and then it gets delivered on a truck or whatever that has to make money, and then it goes to the hospital, and it goes through a pharmacy check, and then it gets administered by a nurse. And so it seems like, well, that's a lot of money, but it has to be done the right way, and it has to be delivered in a safe way. And so it does, when you really stop and think about it, it does make sense. Like, why are these things costing so much? But, you said you want things to be done at a high level of care. You want good outcomes, and it has to go through this whole process. And, you may look at the bill and see that, but then you got to think about the process that it goes through to get to you.
Sure. Like, how does an aspirin become $50 on an itemized bill? And I don't know if that's what it is or not.
I was just making that. I just know that it's more than if you go to Walgreens and buy it.
Yeah. And I'm sure that there's a whole layer of reasons why it gets to that point. And, when you have private insurance that essentially subsidizes, government provided care, that is a large factor in that, because again, the rate that a employee group health plan is going to reimburse for a hospital stay is a lot different than what Medicare is going to reimburse for a hospital stay.
I always ask kind of these three questions to everyone, and that's, what is healthcare doing right? And it's not just hospitals; it's just a generalized. What do you think healthcare does good and is efficient at, or maybe it is just efficiency? What are some things that can be improved upon, or maybe just need a second look or a different way of doing things? And then, what are some ways that you can achieve those changes?
Yeah. Well, that's a lot of loaded questions there. when I look at the things that, from my perspective, healthcare does well, I mean, I can just look at my own organization and the level of care that's provided, that's measurable care, the length of how long somebody lives with a condition like kidney failure. The innovation in healthcare is remarkable, whether it's the technology, the level of care, the outcomes. Um, a lot of very smart people work in healthcare, thankfully, and I think that's one of the things that we do well is innovate. Just because we've always done some things one way doesn't mean we're not, trying to find a new therapy or a new process for doing something. And just in my own organization, I started working there in 2003. 22 years later, there's quite a bit that has changed, even in the way that we provide care. So I think innovation, the willingness to innovate, again, whether it's for a clinical incentive or a profit incentive, regardless, I think that that's a good thing, that we're constantly trying to find new and better ways of doing things. When I think about, we talked earlier about, the doctor kind of being more like a machine. And I think we get very siloed in our healthcare. There's a lot of thoughts around, a lot of folks see, maybe even dozens of specialists at sometimes. And there's not just one doctor that kind of looks after them more holistically. You have, all these specialties, and they are just kind of focused on the one thing that they do instead of looking at someone holistically. I think going back to our roots a little bit in that regard would be a positive thing. Again, I'm not clinical. I'm an overweight middle-aged man. But in general, I think, when I think about, you said idealistically, like what would I do to kind of change our system? And I'm a free market person. I would prefer to have less involvement with the government in our healthcare. I think when the government gets involved, it doesn't necessarily incentivize the right things. It doesn't necessarily make things better. Again, this is my own opinion. I think I would love to see less government involvement. But at the same time, I see why the government is as involved as they are. I think that there is a compassion motive when it comes to the government of wanting to fill a hole. And so, when I look at, healthcare as a whole, I even look at like what my wife does. My wife visits mothers and newborns in the inner city. And it's a very needed service that she provides. Helps folks. They have high blood pressure. They don't know how to feed their children. Like there's these things. And I look at even some of the things that are provided as healthcare. And to me, I feel like we're suffering the effect of an increasingly complex society. I think we're suffering the effect of rejecting God's design for certain things. God has a design for families. And when we don't do things according to God's way, I look at like what my wife does, for example. 100 years ago, it wouldn't have been someone like my wife that provided that care. It would be a mother or a grandmother that came in and helped with a new child, right? And that's not necessarily the way that we do things as a society anymore, right? We are more about convenience. We eat way too much, McDonald's and Chick-fil-A, and less home-cooked meals around the table. What's the effect of that, right? It's not hard to see obesity rates off the charts. It's chronic diseases off the charts. Why are these types of things happening? And I think, complex society that we have, the pace that we go at, just go to youth sports, go to this activity, go to this school activity, all things that are good. But I think what we've allowed, the good to replace the best, and having a more of a peaceful lifestyle and things like that have side effects. And I think when you look at the ramifications of that, there's costs associated. In this case, real dollars and cents. When we spend $5 trillion on healthcare, why? And it's not easy answer for that, right? And I'm not a clinician. I'm just sharing an opinion.
And I don't know when nursing homes started, but it used to be that the family took care of the grandparent or whatever. They kept them in the house, or there was a little bit more, I don't know, responsibility, a little bit more of ownership of, I don't know, wanting to take care of them. So I think that's kind of something that's changed in the culture that I kind of see more involvement from other cultures or people maybe that are first generation into the country. Like when they come to the hospital, their
Sure.
family is like there,
There with them.
like they're there, and it's crazy how a lot of the times like the nurses and the CNAs have to do like a lot less work for those like they are like they'll go out and get their food for them. Like they'll go get their food. They're like, oh no, just give me the stuff. I'll give them a bath. And we're just like, well, I don't know. You're in the hospital. Like we'll
Yeah.
do it. But it just seems like that is a big culture change with us. And I do see it with like first generation people that come over. There's a little bit more ownership for their elderly. Seems like.
Yeah. That's interesting. I can definitely see that. I haven't spent as much time in a hospital as you have, but yeah, there's we think about idealistically again, like what could we do to curb costs, and I just see more and more the effects of like mental health and things like that. And so what's the cause of that? I can't imagine that having our children on social media and things like that are a positive thing. And so we think about like what are some of the things that could be done. And I know this is a financially focused conversation, but when health fails, whether it's mental health, whether it's physical health, there's a financial cost associated with that, right? And thankfully, we have a system that's there to provide care that's needed. But one of the things when you look at the skyrocketing costs associated with it, it's not all because pharmaceutical companies are horrible and want to charge more. No, that's part of it. but but part of it is, as a society, we're sicker, we're less healthy, mental health is declining, and so, my worldview would be one of if you do things according to God's design. God's design for marriage, God's design for family, God's design for the Bible talks about a quiet and peaceable life. And I think that there are really grounding and healthy things that come out of that, that affect you mentally, that affect you physically. And so, when I think about like, what are some things like, it's kind of weird to think about it, but just slowing down and having some, kind of, they feel like good old fashioned practices around sitting around a dinner table and having a home cooked meal that has vegetables and meats and things like that are in it, as opposed to ordering from Pizza Hut. As much as I love pizza, that's not always the best choice, right? And what's the Bible talks about like that sin has an effect, right? It leads to death. And when we do things that are not according to God's design, there are ramifications to that. And I think we're seeing a lot of the financial ramifications of that just in the costs on our society.
Okay. Is there anything you want to add about just something that maybe the average person who doesn't have your knowledge about finances, or like healthcare workers, that we see the end, like sometimes we see the bad part of not the bad part, but we don't understand why decisions are being made, I guess. You know what I mean? Like we just see, oh, they sent a nurse home. You know what I mean? Like, why do we got to take an extra patient? But is there like one thing that sticks out that people just may not understand or grasp about the financial side, that would kind of give them just a better understanding of the financial side of healthcare?
Yeah, sure. And I've talked to a lot of clinicians. I support clinical facility administrators and folks like that. And I think they have a lot of the same questions. Aren't we profitable? Like, why do I have to manage this so closely? Or why do I have to send that nurse home? Or why do we have to be so tight on the way we order supplies? And the reality is, you might remember from some of the statistics earlier, as a whole, the healthcare organizations profits are somewhere between 0 and 5%. So although there are very likely hospitals and companies that do well from profit perspective, it's not like they're rolling in it. And I think it's important to know, like I've sat on the side where we're making decisions about hiring. We're making decisions about merit increases and cost of living increases and things like that. And every conversation that I've ever been in has been about fairness, has been about paying, like, we need to pay these folks what they're worth. What does the market bear for these individuals? And a nurse in Tampa, Florida might make something different than a nurse in Minneapolis. That's true. It's more regionalized. But the goal is we don't want to be the lowest. We don't want to have the lowest paid nurses and staff in a market. We also don't want to have the highest paid. If you're paying folks the most, you're likely not being efficient, right? If you're paying them the least, you're probably being overbearing and probably managing it too tightly. And so there's a lot of discussions and a lot of thought that goes into, we want to pay fair, competitive wages. We want to make sure that our clinics, in my case, our clinics, have the right level of supplies on hand. And just because we ask you to count those vials over and over again and make sure that we have the right stock, we don't want to have too much, because then it can go to waste. And then that drives the costs up on the system, right? And thus those costs are, in a society like ours, those costs are shared, like it or not. When you have government as involved in paying the bills like they are, companies that help keep costs down on the entire system. And so I think it's important for folks to realize that that there are costs associated with turnover as well. No organization wants all their nurses to leave because they found more money elsewhere. And if they find that, nurses are leaving to go across town because they're making $10 an hour more or $5 an hour more, oftentimes there's an adjustment that says, okay, well, we need to go through and bump everybody up a little bit because we're not as competitive as maybe we thought that we were. I think it's important to know that. I've sat in on those conversations. I sat at our company headquarters. I was responsible for helping putting budgets together for the whole company. I've budgeted north of $4 trillion in my lifetime in the healthcare space. And there's a lot of thought that's put into how do we compensate fairly. We want people to have good livable wages, but we can't be overpaying as well.
Yeah, it can get out of hand. If you just
Literally.
let the budget go, it can get out of hand. Yeah. Well, unless you have anything else to add, I think we, had a productive conversation. I enjoyed it. My goal was just to give a little bit more of an insight to just people in healthcare, people outside of healthcare, just a little bit more of an idea of where the money goes, why is it so expensive, and just a general overview of the financial world in healthcare. Absolutely. Because it's just something that I think that, I didn't know hardly anything about. And I think most people just don't understand where the money goes, and just the concept of $4 or $5 trillion is still just like, what does that even mean? Yeah. It's just.
I would leave with one thing. I would say, I think what I have seen is there's a mindset, especially among the clinical side of the care being provided, and that is it has to be clinical outcomes or financial results. It has to be either or. And I very much don't subscribe to that line of thinking. I think we can be very efficient and still provide world-class care. The organization that I work for, when you analyze against our competitor, our costs are lower and the clinical outcomes are greater. And I think that I would challenge the notion that that just because you have a profit motive, or because that you want to be efficient or productive with the resources, because they are scarce resources, whether it's hours, medical supplies, drugs, whatever, they are scarce resources, that it doesn't have to be either or, it can be and. And I think some of the best run organizations with that visionary leader at the top, motivated, folks around a mission of providing top-notch care, when everyone kind of buys into that and works together to provide that, you can have unbelievable care that's provided at a very efficient, in an efficient manner.
Yeah, that would be the goal, I think. Great care, but financially responsible, and taking care of employees, but at the same time, you do have to make a profit. You want your company to be successful. So
absolutely.
Yeah. All right. Well, thanks for taking the time to talk, and
thanks for having me.
I appreciate all your insights and all the wisdom that you have just from your experience working in the healthcare and financial world.
You got it.